Assalamu alaikum, Sikum al-Khair. Good evening. My name is Ibrahim Sbeih. I am a consultant neurosurgeon, and we are transmitting live from Oman at Sarah Medical Campus in Jordan. We'll be presenting a case of preoperative embolization of vascular brain tumor. Again, these are some photos of the spring this year in Jordan, and these photos took the first place and the prize of the American Academy of Photography. It was done by a Jordanian amateur photographer. His name is Ahmed Diabat, and this is from Al-Qura village, northern Jordan. We'll be speaking about meningiomas, intracranial meningiomas. The maximum amount of meningiomas occur either in the convexity or the parasagittal area. The others would follow. So the cortical and the parasagittal takes most of the tumors, while the basal ones are less. So we'll talk about parasagittal meningiomas. And Cushing and Eisenhardt and Oliver Kroner from Sweden were the first to classify these tumors according to their location along the superior sagittal sinus. That's back in the 1990, so the beginning of last century. And then Brucci and Sendau further classified these tumors according to their relationship with the superior sagittal sinus. So who's Brucci, who's Sendau? Brucci is, he was the president of the World Federation. Jack Brucci, he is, as I said, a friend of ours, a friend of the king, a friend of Jordan. And here he is in my house, and here with the Prince Raed bin Zayed. And Mark Sendau is again a friend of ours, and here we are in Bulgaria with Professor Majid Sami attending the Bulgarian Society meeting. So these two people, they classified these meningiomas into type 1, 2, 3, 4, 5, and 6. Type 1, like this one, is just holding the wall of the sinus. Type 2 is going through a hole in the sinus. Type 3 is really invading two walls of the sinus. Type 4, like this, almost closing the sinus. Type 5, closing the sinus. Type 6, invading to the other side. So 6 types of parasagittal meningioma. So whenever one speaks about parasagittal meningioma, one has to address these points. So this is the artist illustration. This is the superior sagittal sinus, and this is the tumor. The relationship that it goes into the sinus can invade the thorax, can invade the brain, and it will block these veins. So what are the challenges in these parasagittal meningiomas? Size. Of course, the larger the size, the more problematic. Location, whether it is in the anterior or middle or posterior of the superior sagittal sinus. Anterior, middle, and posterior. The more posterior you go, the lousier is the case. And of course the histology and whether it receives a pale blood supply. The challenges in these meningiomas. Challenges in the parasagittal meningiomas are the presence or absence of edema, whether there is superior sagittal sinus invasion, whether there is a skin or bone invasion, whether there is a brain invasion, vascular invasion, which is the sinus, and whether or not you have multiple tumor sites. Other factors are the behavior of the tumor, and that you don't have chemotherapeutic or radiation therapy for these tumors. So the mainstay of treatment of these parasagittal is surgery.
How malignant are these?
Sorry?
How malignant are these?
10% are malignant. And if you leave a benign one, they will turn into malignant. There is abuse and misuse and misconduct and mismanagement and mishaps in this part of the world regarding meningiomas. People don't understand how the meningiomas behave, and I will allude to this. So if you have edema like this will increase the morbidity. And you will find that you cannot resect the tumor well, and these structures are obscure. So edema is very important. Sinus invasion like this, sinus is blocked. So each of these alternating veins that they surround these tumors are very important. So it's blocked completely. If you damage this vein or this vein, that's the end of the patient, because this patient is depending on these collaterals to survive. So if you just take this tumor and damage this or that, that's the end of the patient. These are my cases. I don't borrow photos from books or journals. These are my genuine cases, and you can see the sizes that we have of these parasagittal meningiomas. They are real challenge. Like this, this is in grade 6, type 6. Closing the sinus and crossing to the other side. They can grow, invade the bone, and invade the skin. And the famous example in history of this Indian soldier in the days of the British Empire who could not put the hat on his head because he had tumor bulging out. Bone invasion, so the tumor will grow and invade the bone. Still people, radiologists, still causes hyperostosis. It's no more hyperostosis, this is tumor within the bone. And we have to address that. Meningiomas are aggressive tumors. They will go through the bone into the skin. And they will invade the brain invasion, and you will see this in histology. If there are multiple, this is more to it, it is more difficult. And the other challenge is that they are vascular tumors. So here we have the value of doing endovascular intervention to reduce the amount of blood supply. This is real challenge. So what are the tumors that we can embolize? Meningiomas come first, but of course hemangioparasitomas, meningioblastomas, gliomas, metastases, nasopharyngeal angiofibromas are other examples. The blood supply of meningioma come either from the external carotid, which is almost more than 50%, or from other branches of the internal carotid. This has very much to do with our next topic when we speak about embolization. It's easy, rather easy to embolize branches of the external carotid. It is really tough to embolize these branches. You cannot embolize ophthalmic. Of course people tried it, but you may end with blindness, for example. Let's look at literature and what did they write about this. Preoperative embolization of brain tumors with pile artery on dural branch of the internal carotid artery. So this is a parasagittal parafalcine, and this is the tumor blush, and it was found to rising from the middle internal frontal, and they sort of embolize this. So what are the benefits of embolization of any tumor? You will decrease the blood supply, decrease blood loss. Any unit of blood you give carries a risk. So if you don't give a blood transfusion, that's better. It will shorten your operative time, which is good. It will make the tumor soft, which is good. And all in all, you will have a better clinical outcome. So embolization on the paper is useful. What about complications? If you want to do embolization by angiography, you have the procedure itself, which is hazardous. You will put your catheter in the groin, Seldinger technique or whatever. You may get sepsis, you may get retroperitoneal hematoma. That's why we say to the nurses, check the pulses after the angiogram. Check the temperature of the foot. Check the movement of the feet. Because any of these complications can arise. As you go through the femoral artery, you may dissect it, you may cause aneurysm, you may cause AVM, and you may get bradycardia on cardiac arrest. So angiography is not without harm. And the specific complications in the brain is that you will get headache and vomiting. That's why patients should be observed. The tumor may swell. You are trying to close it, but it may swell. And if you get this, then you have to take the patient to theater immediately. So theater should be ready, the surgeon should be ready. Or you get hemorrhage inside the tumor. And due to this, you may get hydrocephalus, acute. You may get closure of this material going into a normal artery and closing it, causing a stroke, hemiparesis. Your material will go through these small arteries into the vasa vasorum of the nerves and cause nerve deficits. Like the posterior meningeal branch, it gives a supply to the facial nerve. So if you close it, the patient will come out with facial nerve paralysis. It can cause blindness and scalp necrosis. So it is not a simple thing, it is invasive. Let's see some of these complications in literature. Complications of particle embolization of meningioma. This is the blush, this is the embolization, and what did you get? Hemorrhage. Risks of pre-surgical embolization of feeding arteries. This is tumor, which is at the falcotentorial area, supplied by the vertebral artery, embolized, and you get ischemia of the superior cerebellar artery and the posterior cerebral artery. And this could be permanent. Post-embolization hemorrhage. Tumor, embolized, hemorrhage. Tumor, embolized, ischemia. So, the question comes, is there a benefit? Should we be doing these preoperative meningioma embolization? Let's see. I will quote some of the major meningioma surgeons. Nowadays, we don't talk about neurosurgery. We talk about cranial surgeons and spinal surgeons. And with the cranial surgeons, we have a vascular skull-based surgeon, we have a pediatric surgeon, and so on and so forth. So some people, like myself, are meningioma surgeons. Sam al-Mifti, Syrian American, very famous for meningioma surgery, said, I have always been skeptical of the benefits of embolization of meningioma, except in selected cases. So you don't do it just across the table, you select your cases. Bernard George, a famous surgeon from France. Embolization doses not facilitating surgery and does not improve results, even if you do intramural embolization and not proximal fetus. So again, he does not believe in it. Lillian Shaker, a great American surgeon of Indian origin in the States. I do not subject my patients to preoperative embolization unless they are giant-sized tubes. So this is a main indication, giant-sized vascular tubes, not any tumor. John 2 from New York, preoperative embolization increases the cost and it adds to the morbidity and mortality. So these are famous neurosurgeons not accepting to do embolization except for selected cases. So what are the indications nowadays? Giant size, very high vascularity, skull base, involvement of dural sinuses, involvement of scalp and calvaria, and electroanteriors. Not any case, selected cases. What is complication of brain tumor embolization? I looked it up and it ranged from 0 to 21%. I talk about neurological complications, not the general ones. Again.
Permanent?
Some of them permanent, yes. This is a paper, 9% complication, and they are permanent. And this is from Rosen and Lillian Shaker, published 2002. This is another paper from Michael McDermott. Michael is a friend of myself. He is a meningioma man, not only a meningioma man, he's a falcotentorial meningioma man. He loves the falcotentorial meningiomas. And he published this paper in 2011, and he tried to take the feeders of these tumors. He got complication of 2.5%, which is rather good. It's in Urology, American Journal, 2005, at 2.1 morbidity, and 0.5 mortality. So I'm giving you the balance between doing it and not doing it. You have to be selective. What do we use for embolization? Either you close the feeders by coils or balloons, not coils, coils, balloons, or you use particles or you use liquid. Particles could be small, could be large. People like large ones so that they will not sneak through the vasa vasorum of the nerves and cause damage. So spheres, gel foam, PVA are examples of these particles. Or liquid like onyx or NBCA, butyrate and cryoacrylic material. So the particles, small or large, PVA, microspheres, beads as particles, liquids, as I said, NBCA and onyx. These are the cords that he used to close these main feeders, large feeders, or use microparticles to close the small feeders. Here you are, microspheres. You put your catheter in, not me, of course, interventional radiologist, and they will put these particles, they will close the blood supply and cause the tumor to shrink or to necrose. This is a case of onyx, which is a fluid, and this is the picture of it appearing after the embolization. Again, these are pictures, the safety efficacy of embolization using N-butyl cyanoacrylate. This is how it appears. And this is one of my patients. Giant, meningioma parasagittal, causing severe edema, very vascular, we embolized. I think it was done by you, isn't it? This is the radiologist man. And you can see the onyx inside the vessels. There it is. We excise the tumor completely without any complication, and there is the man. That was done a few years ago. So, few points to remember about embolization. Should we be doing it under anesthesia? Anesthesia. I don't know how to put it. Like Russian anesthesia. So anesthesia, whether local or general, it can be done both, but it's preferable to be general. And whether you go deep into the tumor to the capillary bed to close the tumor vessels, you have to be aware of the fluoroscopic time, because all the time you are exposing the patient to X-rays. So have to calculate that. And what about the cost? These are very expensive materials. And one thing, and there are a few papers about that, in some of these materials, once you operate and you use the diathermy, you may get a spark and fire. Would these vessels recanalize? Yes, if you leave them for a long time, they can. You can have vasospasm. What is the good time between your embolization and surgery? And what about the MRI after embolization? And can you do it in calcified tumors or not? Let me finish with this. If you have a calcified tumor, do not use embolization. Cost, vial of onyx, one single vial, is $2,500 to $3,500. And how many vials do you use? Hazem? Depends on, but how many usually?
On average, depends on the size, 2 to 3.
2 to 3. Farid?
Depends on the size of the tumor, I agree, but this price is not.
It's not really
This is
not
America.
no.
This is America.
America is different.
It should be higher here,
No,
Much lower.
hopefully. So what is the optimal time for embolization? It is 2 to 14 days. Why is that? People say it's better to do it early so that the vessels that you close will not reopen. But say, no, wait a minute. Leave the embolization in, let the vessels close, let the tumor take its time to necrose, so that when you go in, it is softer than necrose. So it works both ways. This is a paper from Japan, looking at the interval. They have a large series, very nice paper. They say, everybody says 1, 2, 3, or 5 days. They prefer 7 to 9 days. Let's see some of the illustrative cases of mine. small meningioma, yes?
Jumbo.
Huge. Again, embolization and excision. This one, embolization and excision. It allows you a good excision of the tumors. This was a lady from Egypt, actually, married to a Jordanian with this huge tumor going through the bone, closing the sinus, through the skin. It was malignant meningioma, but again we excised it. This is a Jordanian patient with this huge bilateral parasagittal meningioma closing the supersagittal sinus. Now this is a question, will you go through the sinus to remove the tumor? The answer is yes. And this is how the meningiomas are not dealt with in a proper way. You have to take the tumor from inside the sinus. Risky, needs experience, but this is the way to do it. Leave it inside, will tend to be malignant, and you cannot cure the patient. This patient, by the way, presented with lower limb weakness, and he had MRI of his lumbar spine, and he was diagnosed with the disc, and he was operated for the disc. Simply, if somebody took a hammer and looked at his reflexes, you would find him brisk and not diminished. He did not improve on the disc surgery, so he had arthroscopy of his knees, because he's not improving, until he had seizures and people thought of doing this. So parasagittal meningiomas can present with 1 foot drop. Look at this. I opened the sinus and took the tumor from inside, and I preserved these collateral veins. It's a challenge. Lady, Jordanian lady, with this again parasagittal bilateral.
So how long do you wait, brother?
Wait,
How long do you wait?
2 days.
2 days?
2 to 3 days, yes. Again, this patient with this tumor. This is from Yemen. And this one, look at the sinus being closed. And of course they have bilateral, they have another meningioma there. This was a lady who was pregnant in her last trimester. Meningiomas do swell during pregnancy because meningiomas, they have estrogen and progesterone receptors. And she had headaches, she had blurring of vision, and she was diagnosed with toxemia of pregnancy because they found some proteinuria in her urine. If they have looked into the fundus, they would have found it. How many doctors look into the fundus of patients? You don't need to refer the patient to the ophthalmologist. You have to have the ability to look into the fundus of patients during daylight. So this was an emergency surgery and we saved her life. The question is, do we need to remove all the tumor or just take as much as we can, the so-called decompression? وهي كلمة خادعة منافقة. Doctors use it to tell the patient, we have decompressed your brain. Nonsense. It's a crime. There is something called Simpson grade. Simpson is a British neurosurgeon. 1957, he arranged this classification, still holding, that how much of the tumor you remove? You just remove everything, the tumor, the bone, the dura, you drill. This is called grade 1. This is the best. So if you do that, taking the tumor and the dura and the bone, drilling everything, you have chance of recurrence of 5 to 9%. So even if you are aggressive, they have still high rate of recurrence. If you don't, subtotal, then it is 100% recurrence, and most likely it will tend to be malignant. And that is the practice in Jordan and in the third world countries like Jordan. People just take the meningioma lightly, they take some of the tumor out, and they send for radiation. Another crime. Let's look at these examples. I'm not talking from vacuum, I'm talking about the experience of these cases that I've seen. Again, don't refer to the hospital, I call it sent elsewhere. This is a patient with this tumor. It's rather cystic. Surgery took 10 hours by that particular mediocre surgery. 10 hours. And this is post-op. Nothing. Absolutely nothing. He used to go out every hour to smoke and eat sandwich and go drinking coffee and come back, so that it will take 10 hours, so that he'll earn his money. And I went, oh, okay, we have decompressed the brain, send him for radiotherapy. These are actual cases in Jordan. This is post-radiation. Of course, the tumor is still the same. Not only that, but with all the side effects of radiation.
On what basis they
They had no basis, doctor. They had no basis. It is just a bad practice. These people have no idea about neurosurgery. They have not been trained well, and they just are practicing medicine. And this is what I'm fighting. We are graduating people who don't know neurosurgery. I'm sorry.
ethics?
No ethics, no knowledge, nothing. Another case. These are actual cases of life. This patient also presented to another center elsewhere with this tumor, which is blocking the sinus. What should you do? Take all the tumor out, open the sinus, take the tumor from within, remove the bone that is involved, do duroplasty, cranioplasty. That is the way to do it. Okay? So this is 22nd of September 1999. 30 days later, tumor is still there. هو بالنسبة له عمل عملية, it's just nonsense. So what should you do? Send them for radiotherapy. There's the escapism of neurosurgeons, radiotherapy, and a shunt, and gamma knife. October 99, tumor is still there. Okay, the tumor is stable, so go home. Back in 2005, tumor is stable. كلمة stable is a stupid word that we use. تسأل الممرض كيف ما يقول لك stable? What does that mean? If he's dead, he's stable too. Stable is a stupid word. Does not mean anything. This tumor is stable. Goodness sake. Give me a break. 2007, tumor is stable. Simply because the patient is alive. He is paraplegic, he is hemiplegic, he is blind, he is still alive. So it's okay. 2008, that's when they send the patient to me. Sorry, I cannot help. This is beyond anything that you can do, with the patient's clinical condition being very poor. So the idea is that you have to go for maximum accession of the tumor. These are not my words. These are the International Meningioma Society in which I'm a member. And this is known for every neurosurgeon around the world. But how many would actually practice that? Our patient is a 37-year-old female, Jordanian. For the last 4 months, she had headaches. Again, headaches is the stupid thing in the Arab world and in the third world countries. We don't respect headaches. الجملة التقليدية, did you have headache? Yes, it was mild headache, زي اللي بيجي لكل الناس, and it is relieved by 1 Panadol. So it's okay. It is not okay. This is due maybe to a tumor. Unless and until she had seizures, nobody would have cared. She has past medical history of motion picture and restless leg syndrome. She had cesarean section 8 years ago. Her vital signs were okay. General exam was okay. Glasgow scale 15/15. 15/15, another lousy thing. Doesn't mean that patient is well. You may have 15/15 and you have a brain tumor. This is the lady. No neurological deficit except some pronation of her arm. Eye examination was okay. She had 4/5 bowel. And she had right-sided pronation drift. As you said, we keep the patient like this and close their eyes and they start doing this. This is pronation drift. This is the early sign of weakness in her arm and in her leg. Cerebral signs were absent. This is the CT scan that we have done, and we use it also for navigation. To help her financially, instead of doing the navigation MRI, we did this. We put some capsules of calcium on the scar so that it would help us localize them with the tumor. Four-man navigation. This is MRI. Huge tumor,
Stage 3 or stage?
and you can see blood vessels are inside the tumor, which is the most important thing. Look at this. Blood vessels are inside the tumor. This is A2 on the left side, this is A2 on the right side. So the blood vessels are inside the tumor. And if you look at the surface of the tumor, so many vessels. It's very vascular. Again, you can see the beginning of A-com there and the branching of the A2 on the right side, the blood vessels on the surface. Blood vessels on the surface. And again, here you can, this is it in, there is some restriction because it's very vascular and cellular. And this, and I put this for Dr. Abaosh. I asked him to bring his technicians. I have not seen any of them here. This is, we have said that we have a machine that can produce this kind of pictures. But this is a lousy picture. And the technician should be told to give us better results, because the machine here is 3 Tesla, can give us much better pictures like this. Again, look at the vessels. It is inside the tumor. This is on the left side, this is the right side. It is inside the tumor. And this is another challenge. Here, just emerging from the tumor. The same thing in the coronal. Here you can see the vessels. So this is another challenge. Challenge that the vessels are inside the tumor. It's the beginning of A2s, branching. And the MRA, this is the right carotid, paraclival, the cavernous part, the intracranial part, middle cerebral, anterior cerebral. The same thing here. Cavernous part, middle cerebral, anterior cerebral. This is A1 on the left, this is A1 on the right, this is A2 on the right, A2 on the left. Let's follow this, the left. A2 is going like this. While this, A2 on the right, is dividing here inside the tumor. So many things that we learn, you can see one is lower than the other, the left is lower than the right. So you have to have a vision of where these vessels are. The tumor is basically here, and these are the draining veins, the anesthetic veins, because it is resting on the suprasagittal sinus. It's not closing it, but it's impeding the venous flow. Again, we ask residents in the general ward, what is this? They have no idea. And he's supposed to be a neurosurgeon, Dr. Janine, and practice in neurosurgery. They have no idea. Nobody has put MRV in front of them and told them what are these vessels. They would not know that this is a transverse sinus, this is sigmoid sinus, jugular bulb, jugular. They have no idea. The tumor is there, and you can see the deviated vessels. So what's the differential diagnosis? Is all of these parasagitals are parasagittal meningiomas? So why differential diagnosis? The meningoperitocytoma looks very much like meningiomas. Metastatic tumors, cavernoma, parasagittal. And this is Rosae deformans disease, a variant of histocytosis. This is leukemia. This is lymphoma. Alan is not here? Otherwise he would have jumped. Venous thrombosis may look like a tumor, abscess, tuberculoma, parasagittal tuberculosis. We still have TB muntasir, yes?
Indeed, yes.
Here in Jordan, not only in Yemen or Saudi
You
Arabia.
see a lot of brain TB too here.
Some.
Yes, we do. Glioblastoma multiforme, parasagittal with neural base and enhancement. So different kinds of tumors. And the most important one is the multiple sclerosis. This so-called tumefactive multiple sclerosis looks like a tumor, like this. So you have to be careful about that. Radiation necrosis, after surgery, with radiation, and you don't know that it's a tumor or radiation necrosis, maybe the mild tumor, hematomas, various types of pathologies there. Myeloid leukemia, meningioma, you name it. Why should we bother? We should. Because if we know that this is a lymphoma, there's no need for surgery. But if you do all the investigations and there is no primary lymphoma, then you have to go for surgery, not biopsy. Because if you want to treat lymphoma and you take as much as the lymphoma tissue out, this would help his chemotherapy. Ewing sarcoma looks like a meningioma. Hypertrophic meningitis, very much like meningioma. Blood investigations were okay, kidney functions, liver functions were normal, electrolytes, chest X-ray, ECG were normal. So we did a few consultations. Dr. Maurice is not here, but we consulted him. Is he here? No. Because he had seizure. So he says his EEG, which he performed, showed slowness in both frontal regions, more on the right, which is correct to the location of the tumor. And he started the patient on Ibrahim. The Newton is not that good for females, but for the short period of time it's good. So Muhammad Juma again, he apologized, he has some presentation to do. We asked him to come because we are going to put the patient on steroids and we want to monitor her blood sugar. Two people we consult if we have history of hyperacidity or fasciitis. The endocrinologist, because I'm going to use cortisone, and the GI tract people like Dr. Junaid, because we want to be sure that the patient does not have an active ulcer that will go bleeding with the high doses of steroids. And I always put what they have written so that they cannot escape. Dr. Hazem? Please, Hazem. Please.
مساء الخير. The idea was to evaluate the vascularity and the possibility of preoperative embolization. So what we did, I mean, it was obvious from the MRI that this is a vascular meningioma. So what we do detailed 4 or 6 vessels, angiogram, whatever you want to call it, and you see the feeders. And it was a highly vascular tumor supplied by, usually, I mean, especially with a parafalcine, they have to be mostly dural branches. Dural branches, they come not only from external carotid arteries, but they come as well from internal carotid arteries. And there are a lot of pathways for dural supply from the internal. So it was highly vascular, supplied by mainly dural branches from the frontoparietal and pericallosal branches of the anterior cerebral artery, and from the callosal marginal as well. And usually they are like an anastomotic dural branches coming from the anterior frontal and from the pericallosal artery. And even there was a supply from the ophthalmic artery and from the frontopolar artery. So it was taking about 30-40%, I think, from the dural branches of the anterior cerebral artery. Also, yes, as I remember, it was taken from the ophthalmic artery, from both middle meninges. I mean, these would be like 60-70% of supply would be coming in general from the dural branches of external carotid artery. Even it can be supplied from the contralateral part as well. So this is a vertebral angiogram. This is an AP view and on lateral view. It shows patency of the basal dural sinuses, straight sinus and inferior sagittal sinus, but it did not show. I mean, this is a late phase of anterior cerebral injection, not posterior circulation injection, and it shows that because there is blush here, the superior sagittal sinus is patent, and this was seen by MRV, but you can see that it's compressed a little bit. This is the venous outflow pattern that we see with vertebral or with posterior circulation supply. It did not show anything in particular. Sometimes you see that there are prominent veins, as you see here, because there is a higher flow into the inferior sagittal sinus due to the compression or to the high pressure. Well, many people now, they relate, I think, seizure is to the increase in the cortical venous pressure due to the meningiomas. So this is why sometimes you see prominent posterior venous drainage, like in this case, but there is no particular supply from dural branches. One of the important dural supplies come from pica, but I mean before the B1 segment there is multiple dural branches. So this is a lateral angiogram of, I think, I would guess that this is the right internal carotid artery. So this is the ophthalmic artery, and you can see here there is a dominant branch coming up, which is a dural branch of the ophthalmic artery. You can see the supply from the anterior frontal, from the pericallosal and ankylosal marginal, and you can see the patchy filling of tumoral bed, what we call tumoral bed vascularity, which is parenchymal enhancement. This is left internal. You can see also, I would suppose that this might be from the right side or from the left side, I don't know, but this is the left internal carotid artery. You see that the anterior cerebral artery, A2 segment, is pushed to the left side. Still, it is supplying some of the feeders to the right side. You can see some blush here, which means that there are leptomeningeal feeders coming from even the left anterior cerebral artery. And you can see the supply filling even part of the meningioma here through the ophthalmic artery. This is the ophthalmic artery. This is the retinal brush here. So this is dural branch, a large dural branch because of the demand of the tumor. We can see here the late phase on the venogram. In the late phase, you can see the stasis of the blush. Probably some of the images it shows some necrotic part of the tumor centrally. Maybe this is why we have so delayed blush still staining the meningioma. These are the feeders from the external. This is the middle meningeal artery, and you can see an accessory meningeal as well. And it feeds through the collateral of network between the branches of the middle meningeal. This is the middle meningeal. Also, it's taking from meningeal branches of the superficial temporal artery, and they are having like an arcade here filling part of the central part of the meningioma. This is in the process of embolization. We will select a branch, and we will go into the as close as to the tumoral bed itself, to the parenchyma. This is the parenchyma. All right. This stain, the diffuse stain, is the parenchyma of tumor.
So the tumor is right there, where we see that.
The tumor is this is part. This is one compartment of the tumor. All right. This is microcatheter. You can see probably the microcatheter is here, or maybe we advance it a little bit more, and to start filling the tumor bed. So yes, so we were able to advance the microcatheter into or as close as possible to the inside of the tumor bed, and we started to inject the liquid embolic material. We are using now liquid embolic material because of the complication that has been shown, which is intratumoral hemorrhage. This has been very common with using tricyclic gelatins, which are the embospheres and the polyvinyl alcohol. So we don't do embolization with them because, I mean, it has not been reported to have intratumoral bleeding with the new liquid embolics compared to the particle embolics. So this is the concept. You start filling slowly the tumor, and you fill sometimes the tumor itself. And you will find that when you start to inject, I mean, it will seep into the different collateral supply from internal and external. And this is where you have to be careful so that you would avoid to have cortical infarct or ischemia and infarction. And I think we achieved like more than 70-80% occlusion of the tumor vascularity just by one catheter in the center of the tumor and advancing the liquid slowly and getting the liquid to go and to expand at the periphery of the tumor.
Once you get into that tumor and you start injecting, what is the time element doing
how long does it take?
How long?
Well, it depends on the hemodynamic of the tumor. The concept of going now, the new concept of going into the tumor and embolizing into the bed, which is the lowest pressure in the tumor, is really to fill the pressure slowly inside the tumor and try to reflux back on the so it's like a pool, and then you keep putting like cement in it, and you want the cement to go to the other feeder. This is the concept of the liquid embolic agents. So it depends really on the vascularity and on how much the pressure is low. Usually, on average, it takes 1 to 2 hours.
Sir,
Yes.
how you can judge that you decrease blood supply by 70 to 80%?
It's either you calculate from the volumetric parenchymogram, and you see how much you reduce the parenchymogram enhancement on the last image that you take, or you examine by volumes of the brain itself, how much you decrease the supply by volume. But this is more like an eyeballing thing. It's not you cannot do it accurately on the angiographic machine unless you do a cone beam CT now. You can almost calculate how much more accurate volume of embolization.
You can calculate the volume that has been embolized on post-embolization MRI, not on angiogram.
Just one of the differential, you should put sarcoid. Okay? لا قدام حكي. لا أنا I want to see the blush. The differential we put sarcoid usually. No sarcoid. Dr. Hazim, thankfully, he showed us the. I want the resident to remember this term. This is what we call. Look, yes. Can you go back, please? Yeah. This is what we call mother-in-law blush. يعني الحماية. She come early, she go late. You have the blush early on the angiogram, and you still have even after the venous phase. This is the typical blush for the meningiomas. Okay.
My mother-in-law is always there.
Lucky. So have you done it differently? You have used different material?
It's hard to judge any procedures, but I think they had difficult times always the indication. And I think that's where the debate could be. I agree with Hazem, this is liquid embolics is the way to go. There's definitely, we've seen how particles do have higher complication rates, and that's documented in the literature. But the whole topic is a very diverse topic. And first, I thank you for bringing that up, because first of all, I think people should leave this session understanding that the vast majority of meningioma do not require embolization. That's the number one thing, I think. And the second thing, embolization is not about finding a branch and occluding it. Embolization has to go with, especially preoperative embolization, between me and the neurosurgeons sitting together, looking at the angiogram and deciding which branches that will make the surgeon's job difficult, and I should target that, not finding the easiest branch I could go to and just occluding it, because it may make no difference in the actual surgery. So it's actually a much more complicated decision and should not, in my mind, be taken only by the interventionist, which one to close. Yes, sometimes it is like all these branches from the internal carotid were appropriately not touched because they are high-risk cases. But maybe that's what would have caused your trouble, not the branches that coming from the external. I wouldn't judge that. You would judge that. So that's how I typically approach these cases. My view on the embolization in general, avoid it unless it's necessary, because you really, you put the patient at extra risk that only needed if the surgeons, appropriately skilled surgeons, feels it's needed.
Actually, that's what we did, Hazm and I. We sat there in front of the screen and looked at the angiogram, and we debated whether we should embolize that branch coming from the thumb. She's a young lady, so we did not want to take that risk. So we ended taking those branches from the anterior cerebrals and from the middle meningeal.
Did
I
you
disagree.
embolize anything anterior cerebral?
Branches coming from the anterior cerebral.
Yeah, I think in this case we went to the anterior cerebral.
Yes.
Because there was no images of it.
Yeah.
I disagree with Hazem. It was not 70-80%, it was rather like 30%. I'm sure. Okay. Dr. France, where are you?
Thank you, Doctor.
Dr. France, obviously, he had anesthetized patient twice. Once for the angiogram, which was done 3 days before the surgery, and for the surgery.
مساء الخير. My name is Dr. Firas. I'm an anesthesiologist at Farah Medical Campus. I'll be discussing briefly the anesthetic considerations for patients undergoing pre-surgical embolization. This is usually actually a very neglected subject in our country, especially it encompasses anesthetizing patients outside the OR environment, which is extremely dangerous for us anesthetists and for the patients. So anesthetizing patients outside the OR should never be taken lightly, and the safety of the patient should be the utmost goal for an anesthetist. In this procedure we were involved, as Dr. Ibrahim mentioned, twice, and anesthesiologists are generally involved with this procedure, which may be involved with general anesthesia, conscious sedation, and monitored anesthesia care, depending on many factors. Most importantly, the interventional neuroradiologist decision, which should be a discussion between the interventional neuroradiologist and the anesthesiologist. So as we said, the patient characteristics, tumor location, vascularity, and most importantly, the neuroradiologist or institutional preferences, which dictate which mode of anesthesia you're going to perform. As has been discussed previously, embolization techniques could be diagnostic or therapeutic. And the target should be, as Dr. Farid has stressed, which I totally agree, the target should be the surgery inaccessible arterial feeders that should be targeted, and which makes the life of the surgeon much easier and the life of the anesthetist much easier, because this would reflect on intraoperative outcome in terms of torrential bleeding in case it might happen intraoperatively. Related complications, I wouldn't stress much on the CNS complications because Dr. Ibrahim has went over them, but I just want to stress that preoperative embolization encompasses other complications other than the CNS complications, most importantly the dye-induced nephropathy, which is a very important factor in deciding the post-operative outcome of our patients. So renal function should be followed for at least 72 hours post-procedure. So anesthetic consideration could be broadly divided into two classes: the general considerations like any other procedure, and specific consideration for embolization. The general consideration in this case, which encompasses most importantly, is the remote site anesthesia. It is performed outside the OR environment. If we go forward, Dr. Ibrahim. So there are many challenges to the anesthetist in the remote site anesthesia. Most importantly is the unfamiliarity with the environment, which is an isolated environment. We are not used to the staff. We don't work with them on daily basis rather than on sporadic cases. So every anesthetist, before indulging themselves into anesthetizing these patients, they should meticulously check the cath lab suite environment, the equipment, the available equipment, the availability, and we should be courageous enough if we are able to anesthetize these cases with the available equipment or not. So we should be informing the neurosurgeon and the neuroradiologist whether we have the available equipment and the facilities to anesthetize these patients or not. Because most catastrophes actually happen outside the OR and in procedures that we consider simple, which are not as simple as we might think. The other consideration is the radiation safety, especially for the staff and for the patient and for the anesthetists themselves. We have many radiologists on board, so they are much more expert than me. But if you can compare how much exposure we actually do have in the interventional cerebral angiogram, it's 300 to 500 times more than a simple X-ray. Specific considerations during this procedure is the contrast and flush. And as I stress again, contrast-induced nephropathy is a common complication. It might go up to 12% in these procedures. And actually, I want to stress one point that people take it lightly, the flush that the interventional neurologists use. Because actually they might use in one single procedure, depending on the length of the procedure, you might end up giving the patient 2 to 3 liters on top of the fluids that we are giving the patient. So please be aware and always be meticulous and very vigilant on how much flush the neuroradiologist would use, because this would dictate how much fluids you use for your patient. Otherwise they would easily go into pulmonary edema. And the anticoagulation, of course, because they might use up to between 70 and 100 international units per kilogram. And this sometimes would necessitate, based on the ACT and the activated clotting time, giving protein to reverse the effect of heparin afterwards. And patient positioning. This is extremely important because you are opposite to the patient. You have limited access to the patient in case a catastrophe would happen. So you should use longer circuits, longer tubing, longer everything in these procedures. In addition, one of the most important and neglected points is that the radiology suite is always a cold environment. So always have a bed hugger or a warmer device on board. The anesthetic goals that we always target for every patient, but specifically to these patients, is hemodynamic stability, maintenance of adequate cerebral perfusion pressure, patient immobility, because the neuroradiologist sometimes, most often, they would need the patient paralyzed, rapid management of complications, so you should be vigilant on every step that the neuroradiologist would perform. And smooth and rapid emergence is extremely essential because coughing would increase the intracerebral pressure and might cause disastrous complications. I want to stress on analgesia because embolization per se, especially for the meningeal arteries, would cause actually severe pain and headache after the procedure. So we should be aware of these and give the patient proper analgesia. In terms of cerebral protection strategies, we always target an arterial pressure between 100 and 160, but we have to keep in mind that we have to avoid extreme hypertension, which increases the risk of rebleeding, and we have to also avoid hypotension to ensure that there is no perfusion or ischemia due to low blood perfusion. And I want to always stress to my colleagues that now the recommendations is always to keep the patient normocardic rather than using the old-fashioned hypocarbia to decrease the perfusion, because it proved to be in so many randomized controlled trials that actually hypocarbia and hypercapnia would cause disastrous complications for these patients. In addition, of course, in all these patients, avoidance of hypoxia is extremely important. And keep on board some vasopressors, because after induction, these patients actually might suffer from severe hypotension. And also an arbor tube is extremely important because actually the X-ray machine is always mobile and we are moving the bed of the patient all the time. So a reinforced tube and longer circuits and longer tubes should be kept on board. Thank you very much.
So, cerebral angiography with a diagnostic or for treatment is something you should not take lightly. Thank you. So we got the consent, and we spelled it in a very good way. Craniotomy for excision of a right anterior middle third parasagittal parafalcine, highly vascular meningioma, involving both anterior cerebral arteries and then branches, compressing neural structures, cerebral vessels, lateral ventricles, and extending through the from the right to the left side. We mentioned the consultations that we have done, and we studied the complications. 20% of these patients have bleeding, infection, seizure, increased seizures, brain swelling, coma, and so on. It's a major undertaking. Remember some of the anatomy, we are going there, so we have to remember the sagittal sinus, the inferior sinus, like this. This is looking from the top, anterior, posterior. This is the dura, and underneath you can see this is the sagittal sinus, this is the coronar suture. So we classify this into anterior parasagittal, and this is middle parasagittal, and then the posterior one. Sagittal sinus could be anything, could be small, could be wide like this, with many venous lakes. It's a treacherous area, treacherous terrain for the uninitiated. You have to remember the forks, and we know that the tumor is passing through the forks from right to left. This is the anesthesia chart. It took 8 hours to operate on this lady. And before we started, Dr. Faraz took this picture of this, the embolic material inside the meningeal vessels. So let's see the surgery. So this is midline. We're in the right frontal area. This is lateral. This is medial. This is midline. Here is the left side. And you can see the tumor. So still very vascular. That's why I say it's about maybe 30% that has been included. And this bleeding will continue till the end, till the last piece. But what the embolization helped me with is that some of the tumor became necrotic.
So those black vessels on the bottom, that's
Yes.
embolic material.
Yes, you will see it now as we go through. So again, the whole principle is to debulk the tumor from inside. You can see the embolic material there, the black one. So it made the tumor softer, not much, but softer than what it should be. Because this is the brain, this is the edge of the tumor. So we debulk it from within, so we can go around it. Now I'm going around it. I'm taking the arachnoid towards the brain to protect the vascularity. So you just take the arachnoid to the brain. And you can see now the anterior cerebral here. So piece by piece, there's nothing called one-piece surgery. Like the old neurosurgeons used to do, they put their finger and they just chop the tumor out. On their fingers they will have billions of neurons. Again, you can see the vessels separating the tumor from the brain. Embolic material.
So how did this help you, this embolism?
It became softer. It became softer. You can see I can suck it. And it decreased the blood supply, no doubt about it. If we did not do embolization, it would have been bleeding horribly. This is continuous to bleed, but it is manageable. The reason is that some of the blood supply is coming from the ophthalmic artery and from the anterior cerebral, so you don't want to mess with these circulations. Again, the embolic material. I'm just showing these blue things, which is the... Now I am at the forks, but I know that the tumor is piercing the forks to the other side. This is the ultrasonic aspirator. Back to the circulating tumor again. This is the anterior cerebral on the right side, giving branches to the tumor. So I cut the branches and I leave the main vessel because it will go to its targets, to the brain areas. So I cannot just cut it here, it will cause deficits. I just cut the branches from it to the tumor. Again, very vascular, still very vascular. Here again, this is the anterior cerebral on the right side. I'm just cutting the branch here to the tumor, and then I will take this artery away so that it will continue in passing towards the normal brain tissues. You come here across large veins like this. Some of it is draining the tumor, some of it is draining the normal brain. Again, these are very vital. If you damage them, you cause venous infarct. And venous infarct will not show immediately. The patient will come out normal, and then she will have hemiplegia 8 hours later. So these are the veins that you want to protect. Again, here is cutting the blood supply to the tumor, preserving the normal vessels. So piece by piece. In the future, أنا راح أفتح مطعم وأسوي كوسة وباذنجان and I'm used to that. And also I maybe open a barber shop because I shave the head. The patients have so many talents to use in the future.
Much less stressful.
Much less stressful and more profitable. So piece by piece you go around it. It took 8 to 9 hours, but that's okay.
Are they usually well encapsulated?
Yes, they are. Except in brain invasion, then you will not see planar cleavage. But not like this, you just want to know it. Now I'm coming to the forks. You can see the forks. So this is the tumor inside the forks. Forks to the right. And the tumor is extending to the left side. This is the right side. And this is the forks. And I have to excise. This is called Simpson grade 1. It is not enough that I have removed the tumor. I have to remove the dura that is involved, which is the forks. It's not easy, but you must do it. And in doing so, I preserve the inferior sagittal sinus. So this is the hemisphere on the other side, and this is the hole inside the, and look, the amount of the tumor in the leaves of the forks. Opening the forks of it in turn is an art that a neurosurgeon should master. The sagittal sinus is here. So this is Simpson grade 1. Removing the tumor, the involved dura, the involved bone, and reconstruction of all these structures. This is, you can see the anterior cerebral artery on the other side has been preserved. Hemostasis using hydrogen peroxide. Hemostasis entrenched.
Dr. Ibrahim, when you isolate the anterior cerebral artery branches supplying the tumor, do you dithermy that, or you just cut it and it will stop by itself? How, like the connection between the anterior cerebral artery branch and the tumor?
Sure. You have to know whether this anterior cerebral branch is going to normal brain or it is going to the tumor. So unless you see it going into the tumor, and in my experience I have seen these move into the tumor and then coming out. So I have to really to follow them to see that they are not going anywhere, and just cut those branches going to the tumor.
And just by cutting them, they just stop?
Yes,
You don't need to cauterize them?
you cauterize them and you cut them, of course. Of course.
Yeah, that was...
Okay, histology. Dr. Abu Farsakh is not here. but his associate, Dr. Ghadir Haysen, certified pathologist, and she's a lecturer of pathology at the University of Utah. It's nice to have you.
Good evening. Glad to be with you tonight on behalf of Dr. Hassan. So, we received multiple fragments of the tumor. Histologically, this is the most common histological variant of meningioma. This is meningothelial meningioma. The vast majority of meningioma belongs to this subtype. Yes. Meningothelial cells usually in meningioma arrange in this what we call a swirling pattern in Arabic, زي الدوامة. And these are the samoma bodies. A concentric calcification on the site of necrotic cells. This is common variant of this calcification. This is another field showing meningothelial pattern, swirling pattern, the most common pattern. This area where we have early development of samoma body, this is late section. So this is calcification, basically accumulation of calcium and minerals in the place of necrotic cells. Foamy macrophages, I believe there may be in the site of a small area of necrosis as a result of embolization. The tumor was highly vascular, as you can see here. In another photos we're seeing more vascularity. So here we see multiple vascularity in the tumor. Again, another samoma body. These are the foamy macrophages. Early samoma body, as I said, a swirling pattern of the tumor cells, accumulation of necrotic cells in the center, and we have accumulation of calcium debris. Again, the same. So, I will stress on rich vascularity inside the tumor, and in another samoma body and swirling pattern. And this is the early one. Again. So this is a high power image. As you can see, these are the meningioma cells, originally from the arachnoid cap, the normal meningeal cells. This is the most common pattern. You can have other common pattern like fibrotic meningioma, small cell meningioma, chordoid or clear cell meningioma, which is associated with worse picture. And this is the embolization material, as you can see, black in color inside the blood vessels and surrounding necrotic. The more prominent necrosis we can see in the wall of the blood vessels and the surrounding area. Higher power of the embolized material. So meningeal tumors, we're starting here with the immunohistochemical stains. We use them to characterize the tumor and for prognostic features. EMA is the epithelial membrane antigen, which is a specific marker highlight meningeal cells. As you can see, they take the color brown. This is specific staining for meningioma, confirming the diagnosis of meningothelial meningioma. Progesterone, usually meningioma express progesterone. As we can see, they are increase in growth, and that's why they're more common in female. And this tumor, progesterone was not very high. Some literature associate this with worse prognosis, but not solid لسه في عليه papers. So progesterone at nuclear staining, but the expression was very low. This is only less than 5% in this tumor, which is not the usual case. Usually higher percentage of progesterone expression along the meningeal cells. P63, which was elevated in this tumor, and this is a worrisome features along with next P53, which is a mutation in P53 or P63. In some paper they are associated with worse prognosis. However, next, P67, which is the proliferative markers of the tumor, was 10%. Still, P67 is not along the WHO categorization of WHO grading of meningioma. You know, WHO grading of meningioma, histological meningioma grading 1, 2, 3, and P67, though a proliferative marker used in prognostic marker, but it's not among, even if it's reached 20%, P67 among the proliferation of the cells of meningioma does not alter the grade. So this tumor, this meningioma case was WHO grade 1. There's no abnormal pattern. There was no necrosis, except for the necrosis associated with the embolization. No brain invasion, or any of the features that are associated with WHO grade 2 or 3.
Thank you.
Thank you.
Dr. Robinson said so.
Yes, please.
You mentioned something about the degree of necrosis around the embolic material. Can you go back to that?
Yes, sure.
I'm just interested to know, how much our embolization cause necrosis, how far from the vessel does that necrosis extend?
To be honest with you, I didn't take the pictures, but what I got from Dr. Hussam that there was no much necrosis in the sections that, you know, these sections representative of the tumor, not the whole, you don't section or submit the whole tumor, but there is a necrotic area specifically around the embolized vessels. As you can see, the whole wall of the vessel is necrotic and the surrounding area. Also,
It's probably related to the amount of time
Come on.
being waited after embolization.
Necrosis happens.
these macrophages may be associated with necrotic cells. You know, macrophages are here to engulf necrotic bodies, so they may be associated with necrotic material.
I think this reflects the idea that Dr. Ibrahim mentioned that some neurosurgeons like the embolization because it does make it a little bit softer. Which that's why when you said the embolization just around the vessels, I was interested to see how far is that. 2 millimeter away, 5 millimeters. That's not too much then.
Yeah,
So
it's not
that's
too
why
much.
I'm-
Obviously, not too much.
Would you have gotten more had you waited longer?
Yes.
Even histological evidence of necrosis takes longer time to develop.
Right.
You lose the nuclei in 24 to 48 hours. So if it's 2 to 3 days after embolization, the histological feature, the cell may be death, but electron microscopic, then histological, then grossly features of necrosis, they take time to develop.
What's the time frame until you see it histologically?
Yeah, you need to full 48 to 72 hours, 3 days to see frank necrotic shadow cells. Okay, thank you.
Thank you.
Thank you for being with us. So, grade 1. And if you exercise grade 1 fully, like we did, taking the tumor, taking the dura, taking the pulse, you still have a chance of 5 to 9% recurrence. Imagine if you don't, it's 100% recurrence. And if they recur, you cannot cure them, and you just continue with the no-return journey. She woke up 15 over 15 on the table. She must, otherwise we would not let her leave theatre. And this is the immediate post-operative. These are post-operative changes. There was no tumor left whatsoever. She developed some psychological problems. She's a lady with a good faith, Muslim, and she believed that God is testing her faith to have this kind of a tumor at this early age. So she kept wondering, I'm going to die, God is going to choose me, and so on. So because that was repetitive, and she went into uncontrolled laughing and crying with some visual hallucination, and the fear had to want to hurt her. So we asked for a psychiatric opinion. Dr. Samawi is not here.
This was immediately post.
No, that was about 48 hours later. So it was treated with medications, and she went well. And this is the CT showing the embolic material, but there's no edema, no complications. And this is the patient, and this is a discharge summary, fully detailed discharge summary. So in conclusion, one should attempt at complete removal. Complete removal, that's the message. Including sinus invasion. Open the sinus, go for it. Do not be afraid to operate on the sinus. Those who are afraid are those mediocre surgeons who have no idea what to do. That we finish. Thank you. Any questions, Mr. Hadidi?
For the imaging, MRI usually underestimate necrosis. Okay? Intravenous contrast does not show you the real necrosis or the dead tissue. Intra-arterial contrast, when you say they use it, they catheterize and they use MRI with intra-arterial injection. Now there's the 3D susceptibility imaging is used for evaluating the necrosis on the tumor. These are for imaging. For the embolization, the doctor.
Well, by embolization, you don't see necrosis immediately. You never see that. so we don't evaluate. We just evaluate on the area of loss of parenchymal enhancement immediately, and we calculate the volume also. just volumetric, and most of the machines you can do that really accurately. You eyeball it, but unless you have a cone beam CT now, you can see how much of contrast deprivated area that you have created. So we don't see necrosis immediately at all. You need follow-up imaging to see.
It's a few days, 7 days, 8 days now.
I just wanted to kind of, probably for people who, as good as embolization is, every time I do a preoperative embolization, I really think 10 times before. The reason for that, I think if you do them enough, you will definitely be burning. And I still remember one of the worst complications I've ever seen. I was just entering my practice. My senior partner just did a very similar case like this. He had like 30 years of experience. Did the embolization, young patient, 20-year-old, went to the floor. I am on call. 7 p.m. I'm still in the hospital finishing cases. And I get this call that the patient who just had the, this was in Michigan, Spectrum Health. Anyway, so I get this call and she has decreased level of consciousness. Her surgery is tomorrow. We bring the patient immediately down for a CT. Huge hemorrhage. 2 hours she was dead. She went to surgery right away. She was dead. So what I'm saying is, obviously, you put that in perspective, that's a very low chance of happening. And not that this was the only complications we've ever seen. We've seen other complications with liquid embolics. If you do this enough, you will have complications. So it's always a hard, really question, especially with meningiomas. I think we should not generalize this for all preoperative tumor embolization, because you're talking about JNA, if you're talking about glomus, that's a completely different story in my mind. But meningiomas is a topic by itself. So I just wanted to throw that in there. It is really a hard decision to do that before every case. Thank you.
If you have not done enough, you will not have complications. If you do enough, you will have complications. And I remember in a conference, a Jordanian neurosurgeon stood out there at the podium speaking about his experience with 6 cases of pituitary adenoma, saying proudly, I had 0 mortality, 0 morbidity. The answer, of course, because you have done 6. If you have done 100, you will have complications. So any neurosurgeon, or a surgeon for that matter, who stands up and says, I did not have complication, is a liar, or he is just a beginner.
Once you do embolizing, what I know, I'm not an interventional neuroradiologist, I'm an imaging, so I can talk about MRI. But what I remember that the complication on the embolization is low, very low. It is even less than the doing an angiogram. So what he said that there is no role for an amateur interventional. They should be very experienced to do that. Can we go back for the... I have been in America in the RSNA in December, last December, and there was a lecture from Stanford, and he talked about the embolization. Patient which you do embolization. Lista. And what he said, whom patient you have to embolize. Yeah. Yeah. The criteria. Size, location. Yeah. No.
No. There was one before.
Yes.
Indication.
Yes, indication. So, what I remember we told, the size is important.
This one.
Yeah. He said the size should be less than 6 centimeters. The size which is become bigger, the complication is more. The location, he said the skull base is the worst. The best is on near the convexity to do embolization for them. The material, he said the liquid is the best. and the particle is not good, the liquid, because it is take less time for embolization and less contrast, less imaging, especially on the pediatric age, if you are doing something on the pediatrics. The complication of what he said about the size, the location, the materials he used, and there's one more I'm not recalling, that, yeah, he said that embolization will not have difference in the amount which the patient will lose during surgery, but it will affect the time of surgery. So the time of surgery will be less with embolization. This is what he is, and I don't recall his name, but this is what he said.
I'll comment on this. Well, when embolization came up for two ideas in reality. And not only as pre-op, it came up as also as a definitive treatment. And there is a lot of articles. Could embolization be a definitive treatment? This has failed. I mean, in certain cases, yes. In certain cases, yes. But I mean, it didn't provide a solid. We couldn't provide a solid evidence. Though some people they use it as definitive treatment. Probably one of the largest series that I have seen, one of the University of California, San Francisco, and Jack Murray, and he had a lot of cases, and he presented a series with total embolization and no need for surgery in 30-40% of his series, which is weird. So it came up as an idea that can we do embolization to stop, to defer surgery? In few cases it might be. And then came the idea that we'll do it just preoperative to improve the outcome. And unfortunately, unless probably 2 or 3 series, one by Jack Murray again, and one by Saru, who presented a lot of papers on tumor embolization. They showed that the average complication rate is really between 2 to 7%. The most important complication is the ischemic complication, not the bleeding. We have started liquid embolic embolization here since 2000, probably 9 years ago when we had the liquids. I used to work in the army, and because of this idea, we were doing many embolization for glomas. Yes, we had one bleeding. Probably we did like more than 120 cases of embolization. We had one bleeding with the embospheres, and after that we were much more cautious. But with liquid, we haven't seen bleeding embolization. Really, I haven't seen. I've done probably more than 30-35 cases for meningioma. We have seen ischemic. And sometimes it depends on collaterals that you don't see during embolization. So yes, it is rather safe. The rate of complication is really not high. In most of the literature, even with the UCSC, more than 300 patients, they caught a complication between, their complication rate was about 3.4, and mostly they were ischemic as well. So it can be done, but the real value of really what it provides for the neurosurgeon, this is, I think, the most important to evaluate, because we have been doing this. Well, I'll tell you something. Today, we had a case, small parafalcine, with seizures 3-4 times per month. Seizures. She's on antiepileptic drug, and he's a male, and he doesn't want to go to surgery. So I'll tell him, I'll check and see if you have a vascular supply and to embolization. Though we consent him that we don't know the value of embolizing him, what will happen to the seizures. And really, this is one of the areas that I have seen it's lacking in the literature. Many patients, their first presentation is seizures. I think 30-40% of meningiomas they present with seizures. And if you do just embolization, would the seizures stop? This is a question I haven't seen an answer in the literature, and we don't know.
So with the patient, would I offer treatment? You offer them treatment for the seizure?
No. I just offer them treatment if it is a vascular, just to do embolization.
Because he doesn't want surgery.
Because he doesn't want surgery. He doesn't want to do surgery.
The tumor of foramen. But
regarding embolization as a treatment of tumor, if you go deep in meningioma and angioplastic theory of meningioma, if you close the blood vessels recently, okay, or let's say you close all the blood vessels, okay, now the angioplastic